Hi everybody. Tonight I'm going to present on the article Telecare Collaborative Management of Chronic Pain in Primary Care. These are the first 8 pages of the article. The last 2 were the reference pages. And if you want to find the article, here's the article reference. So my article was a quasi-experimental quantitative research article because the study determined the effectiveness of interventions in predicting and controlling the outcomes desired for patients. So the article described the effectiveness of telecare intervention for chronic pain in patients. The research question here is telecare intervention effective for chronic pain? And the problem is that chronic musculoskeletal pain is among the most costly, widespread, and disabling medical conditions. However, there are few research clinical trials out there that have examined the interventions to improve chronic pain in primary care especially. The purpose of this article of the research is to determine the effectiveness of telecare interventions for chronic pain in patients in primary care. The hypothesis stated was that optimized analgesic management provided through a predominantly telephone-based care management approach would be superior to usual primary care in improving pain outcomes. The independent variable here is the treatment, which is the telephone-based care management, and the dependent variable is the desired outcome, which is chronic pain improvement. Now, the theory of this all can be based on many different theories. One theory that I found is the health promotion model, which was presented by theorist Nola Pender. So she states in the theory that good health is not the absence of any ailment or disease, but it's rather a state of well-being. And it looks at every individual in a unique way and their interactions with their environment. So the theory looks at the steps in which a person can pursue better health. So it takes into consideration individual characteristics, individual experiences, and any behavior-specific cognitions. And it looks at all that, and it looks at the behavioral outcomes of a person. Like, how do these all affect each other? So the population this study was done on are patients with chronic pain greater than 3 months, chronic musculoskeletal pain of at least moderate intensity, which is pain score greater than 5. These patients were veterans aged 18 through 65 years old with pain that was musculoskeletal, moderately severe, and persistent despite trying at least one analgesic medication. The individuals excluded from this study were individuals with schizophrenia, bipolar disorder, active suicidal ideation, moderately to severe cognitive impairment, any current illicit drug use, or patients with terminal illness. The setting was at a single VA medical center in Indianapolis, and the patients were patients taken from 5 primary care clinics or 5 primary care doctor panels. This took place from June 2010 through May 2012 with a 12-month follow-up in June 2013. The sampling method used was a randomized controlled clinical trial. So basically they used EMRs of physicians that were participating in the study, and they identified patients that had a musculoskeletal pain diagnosis and a visit within the past 12 months. They sent out letters to patients that explained the study, and they were followed up with an assessment of their interests and their eligibility. The eligible patients that were interested were scheduled for an initial study visit, so they came into the center, and they were provided with informed consent, and a baseline interview was conducted by the research assistant. After the interview, the project coordinator conducted randomized assignment to ensure the two research assistants were blinded to, or two research assistants responsible for the outcome assessments were blinded to the treatment group assignments. And randomization was classified by patient opioid medication use at baseline based on the responses of yes or no. Now, the data collection methods were assessments, and the assessments were conducted at baseline, then at 1, 3, 6, and 12 months by a researcher blinded to study group assignment. The pain was assessed using the BPI, or Brief Pain Inventory, which ranked pain on the following 4 topics: current, worst, least, and average pain within the last week. Now, it looked at this pain level and how it interfered with 7 different areas of their life: mood, physical activity, work, social activity, relations with others, sleep, and enjoyment of life. The primary outcome was the mean group difference in BPI total score during the 12-month trial. The instruments I said that they used were internet and telephone care, and they also mailed out letters. Now, the intervention group included 2 components: an automated symptom monitoring and optimized analgesic management by a nurse care manager and physician teamlet. So they had automated symptom monitoring and care management. In the automated symptom monitoring, the intervention group underwent interactive voice recorded telephone calls or by the internet. And for the nurse and physician care management, the teamlet discussed the plan in an initial phone call, and then they scheduled interventions calls periodically throughout the trial. Other calls that were scheduled were if the patient called to say they were having any adverse reactions, if they needed to change any medications, and if they were having inadequate pain improvement. Now, that's the intervention group. Now, in the usual care group, these patients just continued to receive care in the usual way for their chronic musculoskeletal pain, and there was no attempt by the study personnel to influence any management. Now, the statistical methods that they used here were analysis for change and analysis for improvement. These methods require that the study design include a baseline measure for the patients, and they also required the comparisons of the effectiveness of the treatments. The results of the study were excellent. The study participant follow-up rates were completed by 99% of the participants at 1 month. At 6 months, it was 98%, and at 12 months, 95% of the patients responded. These are just the assessments. Now, the pain outcomes, in comparison to the usual care group, the intervention group had a significantly greater improvement in the total BPI score. Patients in the intervention group were 2 times as likely to report a 30% or more improvement from their baseline score by 12 months. They were also significantly more likely to report global pain improvement. It's 55.8% versus 31.2%. Now, the reliability of this. Are the results reliable? Yes, the results were very valid. As you can tell, they had 99%, 95%, and 98% percentage of follow-up at different periods throughout the study. The patients also shared all similar factors for pain and the circumstances, and they're also randomized into groups blindly by the project coordinator. They also had excellent methods for measuring the outcomes. Now, what are the strengths and weaknesses? The results were very reliable. They were clear, concise, and organized to develop the evidence. They had clinically significant positive effects of chronic pain. Therefore, this could help the future of nursing care. It's very useful, especially for people that have difficulty traveling due to disabilities, any monetary issues, distance issues, and it's just overall convenient telephone care. They also separated the patients that had schizophrenia, any cognitive issues that might give different responses to, might have different responses to pain. These just had different experiences than the general population. Lastly, the summary provided very clear evidence and proved a correct hypothesis. Now, the weaknesses were that this is a very specialized population. This is done on veterans. It was also, they also have a different experience versus the general population because of the circumstances they may have experienced. They also may have a different perspective of pain. A vet that may experience pain isn't also always shared with the entire populations, especially if they've been in combat. They also didn't specify if they were all men or women participants. And lastly, there was no evidence, I didn't find any evidence of researcher bias. Now, what are the ethical and legal concerns? One was that as primary telephone care and internet use, we don't know how secure those messages were, how secure the programs used were, and we don't know the extent of the phone calls. Were they in a private office, or were they in an office that like everybody could hear? We just don't know the privacy. How private were these phone calls? The other legal concern, which was great, was that they did say they had legal consent from the patients. Now, relationship to practice. This relates to practice greatly, especially in our nursing care, because it showed that telephone care was useful. The findings of the study showed that telecare collaborative management substantially improves chronic musculoskeletal pain. Therefore, it's useful in nursing to monitor and follow up with patients. Now, what are the nurses' role in this study? The nurse's role is the initial phone call and scheduling the telephone appointments in the future and keeping track and following up. And the role explained was the nurse care manager. The nurse care manager took the patient health history, any allergies to medications, if they were having any adverse reactions to medications, and they formulated the treatment plan with the researcher, the provider, and the patient, all within the study design. They also provided any interventions for pain. So in summary, I went over the question, the problem, purpose, hypothesis, the independent and dependent variables, the theory that this is based on, the population and setting, the sampling method, the data collection methods and instruments, the statistical methods, the results of the study, if the study was reliable, the strengths and weaknesses, any legal concerns, its relationship to our practice, and the nurse's role in this study. These are my references that I used, and thank you for your time.